This program is brought to you by Stanford University. Please visit us at stanford.edu.
Okay, I thought I would disclose that I do have some grant support from a couple of companies that make vitamin D products, and I am going to have some off-label discussion of the use of calcitriol, the active vitamin D, for cancer therapy. So I wanted to say that at the outset. So this is what I'm going to try to accomplish in this 30 minutes or so. I'm going to start talking about the classic actions of vitamin D, give you an idea of what vitamin D really does as best we knew it over the past years, but then focus on what I'm calling the expanded actions, the new ideas that vitamin D has a lot of actions quite apart from regulating calcium in bone. So we'll start with a bit of history. The classical view has always been that vitamin D is necessary to make your bones normal and prevent rickets or osteomalacia. What is rickets? It's a vitamin D deficiency disease. It happens in children where they get very major abnormalities in their bone. They have soft bones because the osteoid, the collagen matrix, is not mineralized and hardened the way it would be in a good normal bone. So they have very abnormal bones. I'll show you some pictures in a minute. Whereas in adults, they get the same disease, but we call it osteomalacia. They also have this softening, but they don't get many of these changes in their bone grossly, except that they do have the risk of fracture. So the important point here is that vitamin D is required to prevent this disease, and we get it either from the diet or from sunlight. Unfortunately, in the diet, there are very limited sources that are useful to give us vitamin D. In the U.S., milk is supplemented, and that's an important source. However, a lot of us avoid milk, especially as we age. Sun is the main source, really, in the world, but because of sun safety and the concern about too much sun causing damage and cancer risk and so on, people avoid the sun as well. So we now have an epidemic of vitamin D deficiency. It's very common even in so-called sunny places as we live here in California. So this is the historical view. We recognize the importance of vitamin D during the Industrial Revolution in London, where the smog and the slums came together to cause real epidemics of osteoporosis, osteomalacia, rickets. And this is what a child, it's an ugly picture, unfortunately, but this is a kind of a way to show you a few of the findings. You see the bowed legs, which is the classical change when the soft bones have to support the weight of the child. There are many important changes in the joints. This is what a real child looks like. She looks pretty good except for the rickets, and then the miracle of just giving her vitamin D has cured her. Now, this is to remind me that you can get very severe changes in the chest wall so that these children get severe and even lethal pneumonia. So rickets in children can be quite serious when you get this sort of a chest wall abnormality. Okay, so let's get a little bit into the physiology of how vitamin D is formed and how it acts. You can either... This is very difficult to see. You can try and turn around. You can, maybe I'll do it this way. So you have UV light hitting the skin and converting 7-dehydrocholesterol, the precursor that's in the skin, into a vitamin D molecule through a complicated reaction that we really don't want to go into here. Or you can get vitamin D from the diet. And these molecules, the circulating vitamin D, is really an inactive molecule. It requires 2 hydroxylations to convert it to an active hormone. The first one is in the liver, where there's a cytochrome P450 enzyme that will convert the vitamin D to 25-hydroxy-D. This is the molecule that we measure in the blood when we want to know the status of vitamin D in the person. This is the best measure of vitamin D stores. but it's really an inactive molecule itself. It gets converted in the kidney for a second hydroxylation to the 125 dihydroxyvitamin D. So this 1-hydroxylase in the kidney is the critical enzyme to give you an active hormone. The kidney also has, alongside the 1-hydroxylase, it has the 24-hydroxylase, which is an inactivating pathway. And this is one of several ways that the body tries to protect itself from having too much active calcitriol around. So when the 1-hydroxylase acts on 25-hydroxy-D in the kidney, it forms the active molecule 125-dihydroxyvitamin D. I'll try to refer to that as calcitriol. It's a lot easier. Now, calcitriol is like the other steroid hormones in the body. It acts through a nuclear receptor. We call that the VDR, the vitamin D receptor. The vitamin D receptor here dimerizes with something called RXR. That's exactly the pattern that thyroid, retinoid, PPAR, and other nuclear receptors use. So this is a very conventional steroid-like hormone. The dimer binds to this VDRE, which is located in the promoter of target genes, and a variety of genes are regulated. I have a few of them here. These are not the calcium genes. We're going to talk about these in the second part of the lecture, but the main effect is to regulate calcium, and I'll show you that momentarily. Now also, in the target cells, the body has that same 24-hydroxylase that was present in the kidney is also present here, and this can inactivate in the target cell the calcitriol, so that again the body has an autoregulatory process to prevent too much action by the active hormone. Now, this is just to remind me to tell you that the 25-hydroxy-D not only gets converted in the kidney, but we now know, and this is recent data, that a variety of target cells have 1-hydroxylase. And instead of having to be made into the active hormone in the kidney, it could be made into the active hormone in the target cell. This is present in monocytes and macrophages, and we've known for years, for example, that sarcoidosis can occasionally have hypercalcemia. This is the reason for it, that those cells actually can make the active hormone, and if they make enough, it spills into the circulation. It's also present in the breast, the prostate, the colon, important lesions, areas for lesions in cancer, and we think this is the reason that vitamin D in the diet and sunlight and so on may be protective about cancer, because locally it could be made into this active hormone, and we think that that is working more or less as a cytokine locally. So just think of it as really two systems. The kidney is making a circulating hormone, and then locally target cells can make a local cytokine-like hormone, the same hormone, for two different types of purposes. Okay, so the main function for this part of the talk is to regulate calcium and bone. And you see here, well, you see here that vitamin D together with parathyroid hormone acts on the bone and the kidney, but by itself it acts on the colon. And these complex actions are mainly to maintain the plasma calcium and prevent the bones from becoming osteomalacic or rickets. That is, to prevent the poor mineralization of bone. Now, how does it do that? Well, this is pretty new information, but I thought it's worth showing you how, in fact, vitamin D regulates the calcium. This is an intestinal cell, or it could be a kidney cell. And this channel, TRPV5 in the kidney or 6 in the colon, is a calcium channel. And here you can see the vitamin D calcitriol acting to regulate the amount of these channels. They absorb calcium. The calcium is then passed off to a protein called calbindin, which is also regulated by vitamin D. And then calbindin delivers that calcium to these pumps on the inside of the body, and the calcium is pumped into the body. So there's a three-way handing off of the calcium through these channels, transport proteins and pumps to, in a sense, absorb or reabsorb calcium in the intestine and the kidney. So that's a kind of an introduction and a background to give you a feel for what we know about the usual actions of vitamin D. And now I want to talk about this subject that I am calling the expanded actions, and I'm going to have three areas to discuss. One is the defense of hypocalcemia and the prevention of alopecia. Alopecia is baldness, a loss of hair, and that's probably a new idea that vitamin D has something to do with the hair cycle. We'll talk about a summarizing of the diverse mechanisms of many, many diseases that are involved, and then I'll finish up focusing on cancer. Okay, so the defense of hypocalcemia. This is in a way to give you the defense, but also to show you the normal physiology. So if these little green dots, they represent calcium molecules, and if the calcium in the body is low, this is the calcium sensing receptor, which is present in many tissues, but in particular in the parathyroid glands. And they sense that the calcium is low. They stimulate parathyroid hormone. Parathyroid hormone acts through its receptor. And what does it do? Well, one of the main things it does is act on the kidney to induce that enzyme I told you about, the 1-hydroxylase. And the 1-hydroxylase is then going to convert 25-hydroxy-D, the circulating inactive vitamin D, to 1,25-dihydroxy-D or calcitriol. It circulates here bound to DBP, a binding protein. It acts through its receptor that I just showed you, which is a heterodimer with RXR, binding to VDREs. And this leads through the mechanism I just showed you in the intestine to absorbing calcium and repleting the deficient calcium levels. So that's the physiology and how the body prevents hypocalcemia. Now, each of these steps has a protein involved, and every one of these proteins has been found to be mutated and cause a disease. We'll very briefly talk about most of them. So if you mutate the calcium sensing receptor, you can have either activating or inactivating mutations, and either way you get an abnormality, either hypo or hypercalcemia. You can affect the parathyroid hormone and cause isolated hypoparathyroidism. If you affect the PTH receptor, you get something called lethal chondrodysplasia, hopefully a rare occurrence. Now, but this is not a rare disease. When the transducing protein between the PTH receptor and the adenylate cyclase is mutated, we get a common disease called pseudo-hypoparathyroidism. If you don't have 1-hydroxylase, you get a disease of rickets in children. It's a common cause of rickets in children. It has been called vitamin D-resistant rickets type 1, and this second disease, mutations in the vitamin D receptor, has been called vitamin D-dependent rickets type 2, or hereditary vitamin D-resistant rickets is the name we use, and this is a disease I work on, and I'll show you a couple of slides about this disease in a moment. John Adams, who made this slide, which I thought was such a beautiful slide, I'm using it, also thinks there's a vitamin D-resistant rickets type 3, although I don't agree. Anyway, it's on his slide, and I'm not going to not mention it. So this is what the first two children who had hereditary vitamin D-resistant rickets look like. And you can see they have rickets, but also, hopefully, you can notice that they have no hair. They're totally bald on the scalp. They have no eyelashes or eyebrows. They have no hair, period. Now, we have now looked at many, many cases. We don't see the children. We usually just get the cells, which come to us from all over the world. We finally had one case here at Stanford. And we have found mutations in different parts of the vitamin D receptor, which allow us to do two things. One is to figure out how the vitamin D receptor works, how every amino acid contributes to its action, so to speak, but also to provide the physician and the patient with some guidance about what kind of a defect they have and whether, in fact, this receptor could ever be made to respond or will not, as a dead receptor, so to speak. So these are the kind of mutations. This is work done in my lab, mostly by Peter Malloy, but others have helped. And over the years, we have seen many cases. Each of the red marks is a mutation in, this is the zinc fingers, the DNA binding domain of the vitamin D receptor. This is the part that binds to the DNA. And we have mutations that are premature stops so that the total protein is not made. And most of the mutations are present in the ligand binding domain. And the distinction is important because if they have affinity defects, that is, the mutation in the ligand binding domain just decreases its binding affinity, you can sometimes treat those children with high doses of calcitriol and overcome their defect. Whereas if it's a dead receptor, no amount of vitamin D is going to help, and I'll mention in a moment how we treat those children. So just a word about the alopecia. It's found in many of these cases, but not all of them. It's absent in some of the ligand-binding mutants. And although the rickets and the mineral abnormality can respond to the therapy with either calcitriol or calcium, the alopecia never responds. The mechanism for the alopecia is unknown, but there's a protein that has been linked to this defect. It's called the hairless protein. And if it's mutated, you also get an alopecia syndrome. And the interesting finding that just happened is that the hairless protein and the vitamin D protein bind together, and we believe this is going to be the link to explain vitamin D and regulation of the hair cycle. So a word about therapy of this disease. If it's in the ligand binding domain, we sometimes can succeed in treating these people with the children with calcitriol. We do this in their cells, and we can predict whether they're going to respond to higher levels of calcitriol. If they are not, if the receptor is basically inactive, then the therapy is to treat with intravenous calcium and bypass the defect in the vitamin D receptor. And when you normalize the calcium, the metabolic abnormality goes away, the rickets regresses and is, quotes, cured, at least while they're getting the calcium. But the alopecia never goes away. I have been accused of showing this as a slide of 3 grades of alopecia. Actually, this is Zev Hochberg, a collaborator in Israel who has found a lot of cases. This is, as you'll recognize, Andy Hoffman, who was visiting him. And the child has rickets and alopecia. But if you notice, his rickets look pretty good, and he's very robust looking. And he's hooked up to a calcium pump, and he has had his abnormality normalized by his IV calcium, but you see his alopecia remains. Andy and Zev rub vitamin D in their hair every night. Okay, so moving on to other actions of vitamin D, I would say this little list of the actions is what has prepared us to think about cancer and other diseases. So vitamin D has been found to be anti-proliferative in general in many, many cells. It promotes the differentiation of many cells. And it's immunosuppressive in an interesting way, affecting the balance between Th1 and Th2 cells and inhibiting a lot of pro-inflammatory cytokines and stimulating anti-inflammatory cytokines. This constellation has led to its consideration for use in many, many diseases. And in fact, I put this slide in because I think that the subject has been overhyped. This is a Newsweek figure from well, it's almost a year ago exactly to today. But you're finding this in the lay press talking about the wonder vitamin. And the fact that it's going to be useful for cancer, osteoporosis, autoimmune diseases, and many, many others. I'm a little nervous that the hype is setting it up for disappointment. It's a little too much, although we are hopeful that many of these diseases will be benefited by vitamin D. So a list of the emerging uses. Now, first of all, osteoporosis. And here I'm referring to an anabolic action, not just the maintenance of calcium, but to actually stimulate the osteoblast to form bone. And analogs of calcitriol are able to do that. Secondary hyperparathyroidism is the commonest use of active vitamin D analogs or calcitriol itself, and that is a huge market. Everybody on dialysis is getting an active vitamin D, and they're trying now to use in pre-dialysis patients to preempt, if you will, the problem of calcitriol deficiency. Various inflammatory diseases are responding, including IBD. Antimicrobial, this is a very interesting story. It was in the Science journal within a few months ago that calcitriol actually helped the body to clear tuberculous organisms. It stimulated cathelicidin and defensins. And I remind you that before we had antituberculous therapy, we treated people with TB by sending them to sanatoria. Whether that's the reason that it helped or not, we'll never know. I'm not worrying about the time, and I'm not going to read everything on this list. We're going to talk about the cancers, the autoimmune diseases, particularly type 1 diabetes and multiple sclerosis. There's very interesting data suggesting that they could be preventive. There's data on neurodegenerative diseases. Type 2 diabetes, it turns out that the insulin producing beta cells have a vitamin D receptor, and insulin has a promoter for vitamin D. Benign proliferative diseases like BPH and myelodysplasia also show some inhibition of proliferation. And there's interesting data from Chicago showing that the renin system is suppressed by vitamin D, and that there's an important anti-hypertensive effect of vitamin D. So I'm going to focus, though, on cancer because we really don't have time to go into all of those diseases. And the first question is, which cancer? Well, the first one that we found any data for, in fact, the first cancer that was shown where vitamin D had some benefit was melanoma. The second was leukemia. But in fact, the big three today are colon, breast, and prostate. Most of the data exists there, but in fact, there's interesting data recently on pancreas and lung. So at the bottom of this list, I have all with a question mark, and it really may be limited only by the presence of the vitamin D receptor, and we and others have shown that the vitamin D receptor is very, very widely distributed in the body. So what are the indications that vitamin D had anything to do with cancer? Well, the first idea here, and I'm building up from kind of the less important, perhaps in my mind anyway, the less important arguments to the more important arguments. So there's a lot of epidemiologic data called the sunlight hypothesis, that the further away you are from the equator, the less sun you get, and the sun is a kind of a surrogate for vitamin D. And cancer, like prostate, is much higher in the northern climes, and it falls as you get closer to the equator. There are a lot of epidemiologic studies that measure the blood level or the diet or the sun, or they try and make some status of vitamin D from all of that data, and to look at what's the risk of cancer in those people. And over again, studies seem to show that vitamin D is protective. Polymorphisms in the vitamin D receptor can affect risk. That's particularly been shown in prostate. The kind of work I do is to look at cells or animal models. You take cancer cells and you look at what vitamin D does to them, or you have a model where an animal has a cancer, and you treat and look at, in fact, you can slow and even stop the growth and cause the regression of the cancer, which is the most impressive to me of these kinds of experiments. Now, Joellen Welsh did a knockout mouse model. In other words, she knocked out the vitamin D receptor. The mouse does not get spontaneous cancer, but when you expose it to carcinogens, it gets a lot more different kinds of cancer than the litter mates do. So a protective effect that would stop the carcinogen from causing cancer is missing in the VDR knockout mouse. And the most important data is actually to use this in trials of patients. This is a picture of the geography hypothesis showing that here in the prostate cancer, the highest levels are up here in the north and the lowest in the south, and the sunlight is just the opposite. That kind of data, I'm afraid, there's a lot of things could cause that kind of a finding. These kind of slides, they're called smileys, take it one step further. They start at the South Pole, if you will, and they work their way toward the equator and then head up to the North Pole. And the rate of cancer in these countries then follows the same thing. That is, the more sunlight, the less cancer. This is an interesting study that was just published by the Creighton Group. They were treating about 1,000 women with calcitriol for osteoporosis. And I've put here in blue the units that we're accustomed to using. So most of their patients were pretty good. They were in the mid-20s. And one group was treated with extra vitamin D, and they got them up to the 38 level. And it turns out that that small difference in vitamin D led to a 5% improvement in survival. And the survival curve looked like this. It's a small study, I mean, only 1,000 patients. There weren't that many cancers in the 3 years that they're looking at here. But in fact, it was highly suggestive that maybe the vitamin D was reducing cancer risk. Now, I'm going to make this in big, bold print. Not every study shows the same consistent effect, especially the epidemiology studies. 1 week it goes one way, the next week it goes the other way. And they seem to be more happy to trumpet their result when it's negative, to say, oh, we didn't find a benefit of vitamin D. So I'm not going to go through some of those epidemiology studies. Its timing is getting on. The question here is, how does it do it? What does it do to stop a cancer? Well, the list is long. It inhibits cell cycle arrest. It stimulates apoptosis. It stimulates differentiation. It regulates tumor suppressor genes or oncogenes or growth factors and their receptors. It's anti-angiogenic. It inhibits invasion and metastasis. And it's anti-inflammatory. It's a very long list of good things if you want to treat cancer. Now, our lab has done a lot of work on inflammation, and I don't have time to go into it. I don't even have time to read this whole slide. So I'm going to say that although there's many ways that vitamin D is anti-inflammatory, the one I'm going to say just a couple of words about is inhibiting the prostaglandin pathway. That prostaglandins and inflammation have been thought to potentially be important in the etiology of a variety of cancers, presumably, most importantly, in prostate cancer. And there are a lot of causes of prostate inflammation. So here's the COX-2 pathway. Up here you have arachidonic acid, which is converted by the enzyme COX-2 into PGE2, which is the active prostaglandin here. 15-prostaglandin dehydrogenase is an enzyme that destroys the prostaglandins. But the prostaglandins working through these EP receptors do a variety of bad things for cancer. They stimulate it to grow. They stimulate migration and invasion. They inhibit apoptosis. And they stimulate angiogenesis. A very bad profile of effects. And this is just to remind me to tell you that the prostaglandins can be made by the infiltrating inflammatory cell or by the cancer cell itself. This is data from a friend in Florida, Locust Schwarz group, where they looked at their tissue bank of prostate cancer patients. And they stained these sections of prostate cancer for COX-2 and divided them up into the highly stained and the low levels of COX-2. And then they looked at what happened to those people. The COX-2 that were negative had a very low incidence of recurrence, and the high levels of COX-2 had a high level of recurrence. Well, our data, which I don't have time to show you experiments, when we looked at what does vitamin D do in prostate, 3 findings came out all together. That COX-2 was inhibited, that prostaglandin dehydrogenase that destroys the prostaglandins was stimulated, and that the prostaglandin receptors were inhibited. So putting it on a map, here's the arachidonic acid being converted by COX-2 to prostaglandin E2 and doing all these bad things. And here's calcitriol inhibiting the expression of COX-2, inhibiting the prostaglandin receptors, and stimulating the degradative enzyme. So in terms of thinking about how vitamin D might be anti-proliferative in cancer, cell cycle arrest is probably the first one. Stimulating apoptosis is important in some cells. Stimulating differentiation is important in other cells. But we think inhibiting prostaglandins has to be on the list now. So this data has led us to have 3 translational studies here at Stanford. In prostate cancer with Sandy Srinivas, where Sandy is using naproxen and calcitriol to treat early recurrent prostate cancer. With Joe Presti, where we're planning, this has not started yet, to use calcitriol in watchful waiting men. And with Barb Carlson, which we hope is just about to get going, is a trial in breast cancer to use dietary vitamin D in the treatment of the breast cancer. So we are translating some of these findings from cells to the patients and the bedside. And I'm seeing that the time is just about up, so I'm going to speed through this and just show you this last slide. So this is a trial, the ASCENT-1 trial, which took 250 patients with androgen-independent prostate cancer. This is the far advanced bad cancer. These men are going to die of their disease. And 125 of them got docetaxel, the best chemotherapy drug, plus placebo. 125 got docetaxel plus DN-101. DN-101 is a high-dose calcitriol. And this is the survival data. So we're not talking about PSA now, just survival, the most important issue. And here's the placebo curve and the 50% curve for the in other words, docetaxel alone without the calcitriol was about 16 and a half months. And when you added calcitriol, they, in fact, didn't cross the halfway point, even holding the paper up for months until that happened. And it hasn't happened yet, but the estimate is it's going to be 24 and a half months. In other words, a 50% increase in survival by the addition of the calcitriol. Now, that was terrific news. Then the other shoe dropped, and the next trial using the same kind of thing was just stopped. This happened within the month because of increased deaths in the calcitriol arm. Now, it's too soon to know what caused that. It's still being looked at, but interestingly, the docetaxel was different in the control group and the treated group, and so the people on the inside think that that's the problem, that it's a docetaxel difference. Just to mention this, that there were people who were treated with Taxotere and failed to respond. They became the so-called non-responders or failures. When they were retreated with Taxotere and calcitriol, they now were able to respond again. So a very interesting new finding. So I'm going to stop at this point and just kind of summarize that in prostate cancer you have this whole spectrum of disease. We think vitamin D might have a role in preventing the disease. At the time of diagnosis, I haven't shown you this data. There's actually data suggesting that if you're deficient, you have a worse course, and if you're adequate in vitamin D, you do better. In the early recurrent, Sandy Srinivasa's trial is showing that calcitriol plus a nonsteroidal delays progression, which in this disease of elder gentlemen, it's not a bad thing to get delay before you have to go on to the next therapy. And I've shown you some data in the far advanced cancer where, at least in ASCENT-1, it looked as though there was a great benefit of adding calcitriol to the chemotherapy. So these are the people in the lab who did the work, and these are some of my collaborators. And because of the time, I'm going to stop here and try and handle discussion.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.